Hi there, this is Dr. Evan Osar, developer of the Integrative Movement System. Welcome to this edition of Integrative Movement Insider. And this is part 2 of a 4-part series on the psoas, glutes, and anterior pelvic tilt position. Because if you've learned the same information like I learned over 20 years ago that everybody has an anterior pelvic tilt, and everybody has a short, tight psoas from sitting too much, everybody has weak glutes. And early on in my career, as I discussed in the first video, I wasn't able to help a lot of clients with that information. So even though I pulled everybody into posterior pelvic tilt and taught everybody to strengthen their abs and strengthen their glutes, not many people actually got better. Not many of my patients actually got better using that strategy. So we did a lot of intensive research. Janice went to see Sean Gibbons way back in 2005 because he was the only individual in the world at that time that we knew of that was researching the psoas and the function of the deep glutes. And then as I wrote the book, The Psoas Solution, I looked at all the research on the psoas. And as I shared with you in the first video, so if you missed that, watch that video as well, the psoas is really not a contributor to the anterior pelvic tilt because it doesn't attach anywhere in the pelvis where it can pull the pelvis into anterior pelvic tilt. And it really is not even an effective hip flexor. The sartorius, rectus femoris, and TFL are much more effective hip flexors. So what does the psoas do? It helps to stabilize the trunk, spine, pelvis, and hip complex and really center the ball within the socket, the femoral head within the acetabulum. Now, let's turn our attention to the glutes. What's the function of the glutes? Obviously, it's to extend the hip. But if we look at the attachments of the Glute Max, for example, the Glute Max attaches to the pelvis, sacrum, and coccyx. It fascially blends into the thoracolumbar fascia to attach to the opposite lat. So the right glute blends into the thoracolumbar fascia to attach to the opposite lat. Then it goes down into the IT band, which goes down to the outside of the knee. The glute also goes down to the gluteotuberosity. So as we look at that muscle and say, is the Glute Max really just a hip extender? Absolutely not. It's really a stabilizer of the trunk, spine, pelvis, the sacroiliac joint, as well as the hip, knee, and ultimately the lower extremity. So if we look at that function, evaluate that function of the glute as well as the psoas, we see that these two muscles function much more as synergists rather than antagonists, that like the way many of us have been taught. So if your client has a psoas issue, they probably have a glute issue. If they have a glute issue, they probably have a psoas issue. And it's really not about weakness or tightness, it's really about strategy. So in this video, I want to share with you a very simple assessment, because what you want to do with your assessments, and this is part of the integrative movement system approach that we created, our proprietary approach that we created and teach as part of the Integrative Corrective Exercise Instructor Program, as well as the Integrative Movement Specialist Program, is you need a specific approach to identify your client's non-optimal and inefficient posture and movement habits. And then once you've identified their non-optimal and inefficient posture and movement habits, you want to help them develop more optimal and efficient habits for posture and movement. So next, I'm going to demonstrate a very simple assessment for the psoas, and then we'll go into our most common, our go-to strategy for improving alignment and control of the thoracopelvic cylinder or the core of the body so that you can get more optimal and efficient function of the psoas and glutes. One of our go-to assessments to assess our client's hip flexor length is the modified Thomas test. However, we just do it with a slight modification. The setup is exactly the same as the traditional test. However, how we interpret it is slightly different. First, we'll have Sarah sit herself at the very edge of the table and then pull her right knee in towards her chest and hold it there throughout the assessment. We'll have her lie back, maintain this knee in towards her chest, and then assess the position of her thigh and her knee. Ideally, we want her thigh in line with her body here. So she's got a little bit of abduction of her thigh, so that tells us there's some shortness of her abductors. We want her knee at 90 degrees, so she's got a little bit of shortness of her long hip flexor, so her rectus femoris. And we want the thigh relatively parallel to the table or the floor, and her thigh is relatively parallel to the floor. Now, some clients may have their leg up in this position, and we've often been taught that this is short psoas. And unfortunately for a lot of our clients, it's not a short psoas, it's actually shortness in the fascia of their anterior thigh and their TFL, because the fascia of the anterior thigh and TFL can hold the leg up in this position even when the psoas is not short. So the other thing we'll do, and again, we can do this because we can touch our clients. So if you can't touch your clients, you just have to sort of take stock of what you're seeing with your client, is we'll actually palpate in their abdominal wall where the psoas is. If the leg is up like this, the psoas should be, relatively speaking, short and tight. So as you were to palpate in the abdominal wall, it would be ropey and tight. And for most individuals, the psoas is not ropey and tight. It's just the tightness in the anterior thigh from the TFL, the attachments of the rectus femoris, and even the sartorius that holds the leg up in this position. So it's very important that you don't overstretch your client if they're not having psoas related issues. And even if your client does have a short psoas, so they're demonstrating this position right here, and then you palpate and there is a ropey, short, taut psoas, you don't want to stretch those clients either, because that means that muscle is spasmed up and trying to protect the lumbar spine. So you don't want to stretch those clients either. So again, the modified Thomas test, we're looking for shortness of the hip flexors, and most of our clients are most short in the tensor fascia lata, which will pull the leg out this direction and also hold it up into a flex position, and or the sartorius, which will also abduct, externally rotate, and slightly flex the hip. So again, those are the two muscles that are most frequently short and tight and overactive in those individuals that complain about the anterior hip tightness. And of course, you do this, repeat this on the opposite side as well. Now, if you have shortness here and or your client is in posterior pelvic tilt and has that lumbar spine flexion or that hyperextension at the thoracolumbar junction, we're going to move into our corrective exercise strategy next to help our clients create better alignment of their thoracopelvic cylinder, as well as better length through their psoas, as well as their hip flexors, and even their hip rotators and hip extenders.